My name is Elin Schold-Davis. I'm an occupational therapist and a certified driving rehabilitation specialist. I'm the practice manager for community access and driver initiatives at the American Occupational Therapy Association. Today I'm going to be talking to you about safety and mobility for drivers as we age, anticipating changes and distinguishing frailty and fragility from capacity to drive safely. Looking a bit at screening and evaluation, focusing on data-driven decisions and addressing problems with solutions. The role of occupational therapy, addressing driving as an instrumental activity of daily living, and the specialized service of driving rehabilitation, and exploring briefly some interventions for both drivers and caregivers. Driving is the primary mode of transportation in America. Studies show a relationship between health, sense of autonomy, and driving. A loss of mobility can lead to depression, low life satisfaction, health problems, isolation, and loneliness. I hope to try to distinguish driving from car dependence. Living life to its fullest requires engagement and participation in life and all the activities we want to be involved in. The dominance of the passenger automobile is changing. We need to move toward a more global view. The participation and engagement are critical to the health, and we don't have to be car dependent to age in place. Older adults are a very heterogeneous group. The majority of older adults are healthy. Older adults aging with wisdom and care. They seek awareness, they seek education, they take classes, they plan ahead. They make wise changes and self-limit their driving as need be. For some, the aging process is hitting a few things a little harder. They may be experiencing slower processing or have a few more difficulties that they're managing. Community-based education, driving enhancement programs, and services to help plan for driving retirement, even if it's years ahead, are really helpful to assist people as they're navigating more impactful changes. But I'd like to distinguish the group we call medically at risk. This is the group that's facing medically related changes that don't necessarily give them the time to be adjusting to it or understanding it, and maybe in fact impacting the very abilities one would have to make self-aware choices, like in cases of dementia. Changes associated with aging itself are, by and large, changes in vision, cognition, and physical ability. Seniors as they age are resilient survivors and are experts at change. Many make adaptations seamlessly and figure it out. But in the face of medical conditions, medically related changes are not necessarily intuitive and should not be confused with normal aging. Certain medical conditions do impact driving fitness and the capacity. Risk due to frailty and fragility is important to consider. As we age, people sustain injuries more easily and are more frail, which reduces their odds at recovering from injuries. NHTSA did a report that helps us look carefully at this. At crash speeds of 31 miles an hour, the risk of sustaining a serious injury increases dramatically. A 50-year-old female has about a 10% risk of serious injury in a frontal crash, but an 80-year-old female has about a 40% chance. So it's important that we think about safety because of fragility, not just because of competence. CARFIT is the first education program really looking at things like fragility, looking at things like making sure your car is best able to protect you in the event of a crash, and make sure you're comfortable and able to benefit from all the safety features that are within your vehicle. So at CARFIT, we talk about adjusting safety features, talk about how seatbelts are designed, making sure they cross your shoulder comfortably and can be placed low at your hips so that they can hold you in place in the event of a crash, allowing enough room for the airbag to deploy and you would fall into it. For some people, such as when we look at vision, they have difficulty getting high enough in their seat to see well above 3 inches above, at least, over the steering wheel. So if the seat is raised to its maximum capacity and you still are at eye level with the steering wheel, we look at aftermarket solutions such as a seat cushion. There's always pros and cons with aftermarket solutions. They may contribute to moving out of place in the event of a crash. So at Carfit, we talk about the pros and cons and help people make informed decisions. And we really look ahead, looking at solutions for now, and provide some information for looking at possibilities in the future. There are implications for aging in place that are changing. Men and women are projected to outlive what we are calling their driving life by 7 to 10 years. That means driving will likely not be possible for people maybe 7 to 10 years before they'll want to move out of their house. That means what's new in our era of living longer and managing well with health, with various medical conditions that still take their toll, people face a decision to stop that is really relatively new in the last 20 years. Safety requires stopping before the crash. There is no way we can absolutely predict when the last possible day to drive is. So we have to look carefully and intelligently at a number of factors and make decisions preemptively. When? Well, there's no universal test. I'll be talking about the best data that we know to look at, but it's really important that we're respectful of increasing risk and make appropriate changes, because it's about mobility, embracing alternative transportations and making them a priority to get where you need and want to go. So aging with medical conditions, people are living longer, and with that, our transportation modes will likely change. As we have financial planning and living wills, we are encouraging transportation planning. When choosing housing and communities, think about walkability. Think about, do you really want to be car dependent, or do you want to choose a place where there's options? Be a part of the decision to stop. And a word on cessation. For some people, folks that are experiencing the need to stop when they are facing a cognitive change that diminishes your ability to really agree with that change, really we're talking about dementias and cognitive impairment. We have tools such as a driver planning agreement. The idea of this document is for planning ahead, for family members to sit down with their loved one early on with the diagnosis and talk about an agreement. The family member signing and agreeing that they'll do everything they can to explore options and help support their driving as long as possible, and for the driver with the diagnosis to say that I trust that my family will explore options for me staying on the road, will explore options for my transportation options to keep me mobile, and I will give up the keys when they believe it's the right time for me to do so. We all understand that when a person gets to the point where they have to impose this agreement, they may not remember having signed it. But the idea is that the family member can feel as if moving ahead with imposing this restriction is really what their loved one would have wanted. They wouldn't want to be hurting somebody else on the road. They wouldn't have wanted to place others at risk or themselves. And this early agreement can be helpful in that process. And then we can also support the family with strategies, because when you impose an agreement and the person doesn't remember it, you may have to use strategies like altering the keys, moving the hook or the bowl where keys were typically stored, disabling the car, loaning, giving away, or selling the car. And sometimes a physician's note on a prescription pad can be an effective reminder. Understanding driving capacity is an important part of our dialogue. There are many different types and measures to assist us. There's screening to build awareness or justify more testing. But the cut points you have to remember in a screening are not precise. They're meant to give sort of a general idea that this person may be at risk, but they're not intended to say, yes, you are at risk. They're intended to justify that you get more testing. Testing at centers such as your Bureau of Motor Vehicles is going to measure specific criteria for the novice or new driver using a pass-fail criteria, which may or may not be the kind of test needed for the medical conditions some individuals are facing. Evaluations integrate tests and help give a more global view, and the comprehensive driving evaluation is an evaluation that integrates clinical and on-road performance to make individualized recommendations. I'll talk a bit about that as we move along. So there's multiple services for testing, and consumers and practitioners alike need to really understand these different services. They're distinct. They all have a role, but they're not interchangeable. Driving schools offer a road test. Driving schools are education oriented. They're looking at what a person knows and figuring out if lessons would help teach them what they don't know. If their loss of ability is from a medical condition, teaching may not be the appropriate solution. Tests at a state licensing agency are looking at basic knowledge of how to control a vehicle. The first thing learned and really the last thing lost in debilitating medical conditions of cognition in particular. So we have to think about, is going for a pass-fail test the right thing at that time? And the Occupational Therapy Comprehensive Driving Evaluation looks at the individual's capacity, balancing with impairments and figuring out what solutions might be possible. So thinking a moment about driving skills and behaviors that are looked at as we consider driving risk. There's the operational level. That's the basic level of human-machine interaction when your 16-year-old's learning how to drive. When you're learning the new operation of a vehicle, you learn steering, pushing on the brake pedal, turn signals, when to use them, all the physical skills to carry out tactical maneuvers. These are overlearned skills for driving, and they're the longest retained. Tactical are the decision maneuvers made during driving maneuvers, slowing during poor weather, when to make a left turn, or whether to pass at this point or wait a little longer. The highest level of driving competence is strategic, and this is where judgment, experience, decision making comes into play. This is what you gain over time. Determining trip goals. Which mode of transportation am I going to take? Is it a good day to travel or is not a good day to be going? Should I delay the trip? Wayfinding. What's the best way to get there? Coming upon construction, and how am I going to alter my route? The strategic level of driving is the last developed with experience, and oftentimes the first level we see diminished in the case of cognitive impairment. The spectrum of driving indicators for driving and commuter mobility is a model being used with the occupational therapy practice. For access to services, we want to increase the occupational therapy practitioner's capacity to be able to assist you in determining your level of risk and what level of specific specialized intervention is required. So the occupational therapist can really look at how important driving is to an individual that's facing a medically related change, maybe after stroke, maybe after having many different kinds of medical conditions they're dealing with, Alzheimer's disease, or MS, or Parkinson's. They look at routine IADLs and readiness and intervention strategies. They're looking at whether the importance of addressing risk can be taken care of in the clinic, or if a comprehensive driving evaluation is warranted, and at what time. When is the best time for that evaluation to make sure the person is ready and best equipped for that test to give the individual driver who possibly paid out of pocket for that test, to make sure that it was the best time to get it, so that they can really understand and respect the results from that evaluation. Comprehensive driving evaluations and the work of the occupational therapists are data-driven. The OT Comprehensive Driving Evaluation involves three primary components: the occupational therapy, the occupational profile, where we look at the occupations of the individual, their history, their current situation, their goals, how important is driving. For some, driving isn't that important, and they're willing to really explore alternatives earlier, or they've been getting more and more nervous about driving. For others, driving is the most important thing, and we need to put everything toward preserving driving if we possibly can. It's important to understand the importance, because then administering, scoring, and interpreting the clinical tests and evidence-based measures of driving capacity are all balanced within the importance this is to the individual. The functional on-road test is a part of this evaluation where skills are observed in context on the road. A quick review of what are some of these tests involved in the driving evaluation. They look at vision, visual acuity, visual neglect, depth perception. They're going to use evidence-based tools to look at attention, executive function, visual, spatial, executive function, semantic memory, memory orientation, concentration. These are all important cognitive, complex cognitive domains to understand when we look at driving risk and driving capacity. And there's always a physical assessment. Underlying physical capacity, range of motion, neck range of motion, balance, to be matched with possible solutions such as adaptive equipment, spinner knobs. If you have trouble feeling your feet because of diabetic neuropathy, instead of risking pedal confusion and having a serious event happen, could maybe transfer and use hand controls and drive that vehicle very safely for a longer period of time, because you're using a stronger skill set of hand controls and not relying on the impaired sensory abilities of your feet. And we also look at the IADL functional-based performance test on road, looking at those operational skills, using the controls, lane position, the tactical skills, attending to the signs, the reaction, complex intersections, navigating rules of the road, and the strategic, which is the problem solving and managing in complex activities. The comprehensive driving evaluation includes strategic elements. So the OT comprehensive driving evaluation has clinical and on-road that's consolidated into a report. It focuses on identifying both strengths and limitations around driving. It focuses on exploring every possible solution and recommendation. Is remediation recommended? Are there adaptations or vehicle modifications that would help? Could training be the right solution? Or is cessation the only possible solution? Was everything explored and ruled out? And if cessation is recommended, can they initiate a transportation plan or refer to the other services such as mobility managers and social work to look at options to support cessation? Certified driving rehabilitations can be found through two organizations. American Occupational Therapy Association certifies specialty certification in community mobility, driving and community mobility, and the Association for Driving Rehabilitation Specialists, or ADED, has a certification to also credential practitioners who have the advanced education to be able to provide a comprehensive driving evaluation. You want to look for people that are trained. Certification is not required, but recommended. And I also have coined the phrase myself of personal paratransit. I don't ever want to leave out the importance of mobility equipment to support the caregiver. Maybe the individual can no longer drive after their stroke, but maybe they want to go home with their spouse and stay in their home, and but the spouse, although very capable of driving, has physical limitations that make transferring and hauling wheelchairs really problematic. And frankly, that work may contribute to their progressive disability. If they have an arthritis, it can actually be damaging to their shoulders. So maybe as we look at the caregiver, we want to explore mobility options that would make them as a unit have spontaneous ability to go where they want to go. So you can use various transportation providers, or you might look at your own equipped vehicle so that you can, if that swing out seat allows your loved one to transfer into the passenger seat and does not require the physical lift of your body, this couple may experience spontaneity and participation supported by an adapted vehicle. Older Driver Safety Awareness Week is a week offered by the American Occupational Therapy Association and involves many different associations where we try to talk about a number of resources and tools that can be accessed. On our website, on the AOTA website, we have a number of different tools under each of these categories that you can explore, and also look to the first full week in December for media stories and opportunities to get the word out about programs supporting older drivers and their mobility. I thank you for your attention, and if you have questions, you can contact Elin Schold-Davis at eschold-davis@aota.org. Thank you.